A very, a very good evening, a very warm welcome. Myself, Aishwarya Nair, welcome you all on behalf of the Pharm D Community for today's session on dialysis, a complete overview. I'm thankful to all the participants from all over the country who have taken out their valuable time and are attending this evening talk. Pharm D Community has been created with the charter to provide free webinars by doctors and Pharm D doctors. We conduct these webinars solely to pursue interests, facilitate and foster awareness and education in a chosen field of pharmacotherapeutics. Organizing this event wouldn't have been possible without the wholehearted support of my core committee members. Thanks to Kuldeep, Pooja, Vaishnavi, and Yamini. It's my pleasure to tell you about the second session of the drugs that are used in dialysis, and it will be conducted on this Friday. I'm thankful to our speaker for today, Dr. Varun Kumar sir, who is one of India's eminent nephrologists. I'll hand over the session to my teammate Yamini to introduce our speaker for today evening.
Thank you, Aishwarya. Good evening, everyone, and a very warm welcome to you, sir. Our speaker for day one, dialysis and overview, is Dr. Varun Kumar Bandi. Dr. Varun Kumar Bandi has completed his MBBS from Vaidehi Institute of Medical Sciences and Research Center, Rajiv Gandhi University of Health Sciences, Bangalore in 2004. Sir has completed his MD in General Medicine from Jawaharlal Nehru Medical College, KLE University, Belgaum, Karnataka in 2014. Sir has completed his DM in nephrology from Sri Ramchandra Medical College, Sri Ramchandra University in September 2017. Sir has also completed his nephropathology and has been awarded the certification in nephropathology by the International Society of Nephrology, ANIO Clinical Nephropathology Certification Program. Sir has completed the executive program at Indian Institute of Management, Ahmedabad on leadership and delegation program for nephrologists in August 2019. Sir has a professional experience as consultant nephrologist at Arun Kidney Center, Vijayawada, Andhra Pradesh in India. Sir works as an assistant professor, Department of Nephrology, Dr. Pinna Manini Institute, Siddhartha Institute of Medical Sciences and Research Foundation, Gannavaram, Andhra Pradesh, India. Sir holds the memberships at International Society of Nephrology, International Society of Peritoneal Dialysis, International Society of Pediatric Nephrology, American Society of Nephrology, European Renal Association, European Dialysis and Transplant Association, Asia Pacific Society of Pediatric Nephrology, and Andhra Pradesh Society of Nephrology. Currently, Sir is working as an assistant professor and head of department at Department of Nephrology, Dr. Pinna Manini Siddhartha Institute of Medical Sciences and Research Foundation, Gannavaram, Andhra Pradesh. Sir is also working as a co-convener and at Faculty Research Club, Dr. Pinna Manini Siddhartha Institute of Medical Sciences and Research Foundation, Andhra Pradesh. Sir is a member at Institutional Ethics Committee, Dr. Pinna Manini Siddhartha Institute of Medical Sciences and Research Foundation, Andhra Pradesh, and also editorial board member, Clinical Medicine Research Journal, ISSN, print 23269049. With this brief introduction, I now request our honorable speaker to please take over this session. Over to you, sir.
Shall I start sharing the screen?
Yes, sir.
Okay. Okay, so fine. Can anyone see it?
Yes, sir.
Yes, sir.
Can anyone see the fine? Okay, good. So first of all, good evening to everyone. I just tried to give a brief introduction of what dialysis is and the basic principles of different types of dialysis. So after that, maybe once you are you are a bit comfortable with this, then maybe you can interact and we can understand better about which modalities and what better you want to know. Okay, so just a brief introduction about the different things we do with using the dialysis machine, not just hemodialysis, but many things which you do using the dialysis machine. So I'm Varun Kumar, as already given a very generous introduction was given. Fine. So this is the outline of the talk, the principles of dialysis, then what are indications in brief, and then types of dialysis, what type of dialysis we do in ICU, and the other methods which we do using the dialysis machines. Okay. Sorry. So the initial term is renal replacement therapy that includes all the options which are available for patient with dialysis. For patient with end-stage renal disease, that includes not only dialysis, transplant is also part of renal replacement therapy. That's IRT. So in this IRT, we'll be concentrating mainly on dialysis as of now. So dialysis modalities which we know are hemodialysis and peritoneal dialysis. So the treatment options for a patient with ESRD, kidney transplant is the best option. If it's not available, either hemo or peritoneal dialysis, which can again be interchanged depending on the complications or patient profile. Some patients who are not willing for dialysis will just give end of life comfort care. So what exactly is dialysis? It is a process by which a solute present in solution A, whose composition is altered by making it come in contact with another solution with different concentrations. Suppose you put a sugar solution and a salt solution next to each other, separate them by a semi-permeable membrane. So by this, you're altering the sugar content and salt content of two solvents. That is basically what you're doing by dialysis. This was the first hemodialysis experiment done in 1913 by animals. It was the first dialyzer. This was almost size of a bench. It was a huge dialysis machine, which was done in animals. Then this was the first working model in humans, the alveolar kidney. You can see it's almost size of maybe bigger than a refrigerator. And it used to run for around 24 to 48 hours for one patient for one session. So from them, we have come down to many advances now, which we will be seeing later. So alveolar kidney was the first working model for dialysis. So coming to the basic principles of dialysis, there are main two principles of dialysis based on the different types of dialysis work. It's either diffusion or convection, only two things. Many of us would have learned this in physics class some time back. We just go through it again. So diffusion, as we know, it's movement of solutes from higher concentration to a lower concentration when they're separated by semi-permeable membrane. If water moves, that is called osmosis. If the solutes move, it is called diffusion. That's it. The difference in movement of the thing is called diffusion or osmosis. So this is influenced by the concentration gradient. Suppose one side you have 100 grams, the other side you have 0 grams, it moves faster. One side you have 100 grams, and the other side you have 90 grams, it moves slower. So difference in concentration is one which determines the speed. In the molecular weight, we have semi-permeable membrane. So it depends on the size of the membrane holes. Membrane has small holes in that. If a molecular weight of substance is smaller than the hole, it will move faster. It's almost equal to the hole, it will move very slow. And same way to membrane permeability. It not only membrane permeability not even depends on size of the hole, but also the charge. Suppose you have negative charge surface, negative charge molecules will not move. They get repelled. So the charge and the size and multiple things determine the membrane permeability to each solute. All these things together influence the diffusion capacity. So when we come to convection is like most of you have seen. Suppose we have, most of you have seen sink. There be some particles sitting in the sink, some waste thing sitting in the sink outlet. They're just sitting there, not going through. But you put water at a speed, they push down the drain. That is nothing but convection. When water passes, it takes all the things along with it, all the solutes and particles and molecules along with it. Even if the size of molecule is a bit bigger or it is a bit heavier, because of the push of the water speed, the things get pushed into the sieve. That is convection. The simplest example is wash basin. You push water hard, the particles setting on the sink in the bottom, they get filtered off, even if they are a bit bigger in size. So that is called the solvent drag. So when you give sufficient pressure, the water drags the solutes, even if the weight is bigger, which if the weight is bigger, diffusion is not possible. But in this, what happens, because of the pressure, the water takes it along with it and makes it go across the membrane. That is a solvent dump. This is what we use in convection. So based on these two principles, there are different modality of dialysis. So this is your diffusion. This side high concentration, this side low concentration. So the small particle keep moving. This is diffusion from high concentration to low concentration. This is convection. You're putting pressure. So because of pressure, this water moves across. Along with it, it takes whatever particles are there, there in the pot, it takes it along. So this size may be bigger. Even if the size is slightly bigger, it takes. So in convection, we can remove bit bigger solutes compared to diffusion. Diffusion removes very small solutes. Convection removes bit bigger molecules. This is what we say. If a molecular weight, if you take a molecular weight of urea, it's about 113, 100, approximately 100, even creatinine 88. So diffusion is enough to take care of urea creatinine. But most of the toxins which are accumulated in kidneys, we call them as middle molecules. Middle molecules are something between this 1,000 to 20,000. Those are the middle molecules. Those are not cleared by dialysis, diffusion. They are cleared by convection. So up to 10,000, 15,000, the best example is of beta-2 microglobin. Beta-2 microglobin is a middle molecule, approximately 7,000 to 12,000 kilodaltons. That is not cleared by diffusion. That is cleared only by convection. Stemobigai has more than 30,000 kilodaltons. That is albumin. Albumin is 60,000. More than 30,000 is immunoglobulins. Because immunoglobulins, albumin are not cleared even by convection. If you want to remove albumin, if you want to remove immunoglobulins, antibodies, we use what is called as plasmapheresis. Plasmapheresis removes all of them. Whatever is present in plasma, it is taken off by plasmapheresis. So depending on the molecular weight which we need to remove, we decide whether we need a diffusion, need a convection, or if we need to remove the entire thing, we use plasmapheresis. So how do you apply this principle? The principle of diffusion is what is used in hemodialysis. The most of the machines which most of you would have seen is hemodialysis. Convection we use in hemofiltration. These are a bit more technically advanced machines, more expensive machines, and so the patient also charged more. If you combine both of them, best of both worlds, diffusion plus convection, that is called hemodiafiltration. Diffusion plus convection. So the commonest modality which uses diffusion in ICU settings, especially when BP is unstable or post-transplant, post-liver transplant, post-heart transplant settings, when BP is unstable, what we use is diffusion plus convection or convection. So this charge more, but when it comes to outpatient patients, patients on maintenance dialysis who come for dialysis once every twice a week or 3 times per week, who keep coming for dialysis, for them we can use diffusion or diffusion for plus convection. But the number of studies which have done, they have not shown any benefit of convection. They have shown that diffusion is enough. So hemodialysis is sufficient. We do not need hemodiafiltration. Hemodiafiltration is more expensive. So coming to the indications for dialysis. So this is how we do dialysis. Now coming to when do we do dialysis? This is the simplest we can do. AEIU, the other purpose, AEIU. And the patient has acidosis. Remember, one simplest indication for dialysis, it has to be refractory. All indications should be refractory except in presence of uremia. This is an absolute indication. Just all of them are relative indications. So they has to be refractory. If metabolic acidosis not responding to treatment, which is severe, then you do for RRT. Electrolytes. If you have hyperkalemia, hypercalcemia not responding to your medications, then you do dialysis. Ingestion of toxins, again, drug intoxication very severe enough where drugs may not control, or alcohol like methanol poisoning, methyl alcohol poisoning, ethanol poisoning, all these poisonings where again drugs may not help, then you do dialysis. Fluid overload, patients with congestive cardiac failure, patients with pulmonary edema, renal failure causing pulmonary edema, congestive cardiac failure pulmonary edema, liver disease causing diffuse volume overload, anasaicas, where you want to remove water. You're giving diuretics, but patient is not responding. Again, if your medical management is not working, then again you do dialysis. So all these things are first to take medical. When you feel that medical management is not useful, that is when you go for dialysis. But uremia is an absolute indication. Uremic pericarditis, uremic neuropathy, even uremic gastritis. A patient with CKD is end stage, and you have been following up the patient. You are seeing the patient from creatinine is 2, creatinine 3, creatinine 4, now creatinine come to 7, creatinine come to 8. And then patient does not complain of anything. Patient is stable. He's come to you walking, talking, but he just says that, doctor, I'm not able to eat. That decreased appetite itself is a sign of uremia. It is, most of us ignore that symptom. So it's not only pericarditis, not only pulmonary edema, not only neuropathy, just a simple symptom of decreased appetite is also a symptom of uremia. So that is also an indication for dialysis. So these are like absolute indications. Anything related to uremia is absolute indication. Other things are relative indications. So now we come to the first maintenance dialysis. Maintenance dialysis is what we call outpatient dialysis. Patient with end-stage renal disease. creatinine 8, creatinine 9, his kidneys are gone, permanently damaged, right? Acute kidney injury and chronic kidney disease. Acute to recover. Or patients in ICU, sick patients, critical illness, critical ICU, dialysis. But what we are going to see now is the maintenance. Patient is known CKD, he has gone through all the stages, now he has become dialysis dependent, his kidneys are not working enough to support him without dialysis. Then we put them on maintenance dialysis, that is outpatient. He did not get admitted. He come to hospital, usually ideally it is done 3 times per week if a hemodialysis. PD is done at home, but due to logistics, the now frequency in India varies. So what are the options we have when a patient has come to you and the patient is cat of 8, is decreased appetite, some dyspnea is developing, some vomiting is developing, so he's having uremic symptoms now, you have to start him on dialysis. So what are the options you can give to the patient? You have either the blood-based, that is hemodialysis, or the abdominal-based, like peritoneal dialysis, 2 options. Hemodialysis, again, he can come to the hospital 3 times per week or 2 times per week. Generally, India we do 2 times per week because of logistics, money issues. Idea is 3 times per week visit. Or we have something called a home hemodialysis, where patient can set up a hemodialysis machine at his home. He needs to set up a machine along with a water treatment plant. So they need approximately the size of a bedroom. The average 10 by 10 bedroom will be required. For the bed and the machine and for the water treatment, but everything, cost will be approximately 15 lakhs for initiation, for installation of the machines, everything, for the entire setup initially. If it's a home hemodialysis, if a patient is planning for home dialysis, they can do all the short daily dialysis every day for 3 hours in the morning or 3 hours in the evening. Or we can do what is called as nocturnal. Patient connects to the dialysis machine and sleeps. Overnight, dialysis is done for 6 hours or 8 hours. Dialysis is done. Early morning, when patient wakes up, he disconnects. Or attendant comes and disconnects. So this nocturnal can be done on an alternate day, or it can be done on nocturnal day, or every day. So this daily nocturnal is supposed to be good because you're doing a smooth treatment. In center hemodialysis, it's like 3 times per week. So you are doing 3 times per week. Each session is around 4 hours. 4 into 3, that is 12 hours. So we are doing dialysis only for 12 hours in a week. But whereas our kidneys will be working 24 hours in a day. So in-center HD is the least preferable. This is the best, home HD is the best, but usually we do not have access, so we do in-center hemodialysis. Next better is peritoneal dialysis. This is again one of the better options, but due to lack of logistics and money issues and due to the convenience of nephrologists, many nephrologists are not trained in PD as of now. So PD is that's why taken a back seat. Again, you have 2 options: continuous ambulatory PD, where the patient does it by himself, or continuous cyclic PD, where you have machine which connected. Machine will do the PD when the patient is sleeping at night. So coming to hemodialysis. For hemodialysis, the first thing what we need is vascular access, because you need to tell hemo is blood based. You need to take out the blood, filter it, and send it back. Our normal IV lines are not sufficient because they are very small. Our normal veins are also not sufficient because blood flow is very small. What we need blood flows in the range of 250 to 400 ml per minute. If you take a normal radial vein or brachial vein, the blood flow will be 50 to 60 ml per minute. So we need a hugely increased blood flow. What we do is, for that, we either use a temporary catheters, which go directly into the heart and increase the blood speed, or we can get enough blood from that, or we combine the artery and the vein. Either join them directly, we call it a fistula, or put a pipe in between them. Pipe connection between the artery and vein, that is called a graft. So the AV fistulas, AV grafts, or the catheters. So this is the radiocephalic fistula, most common use, where the radial artery is joined to cephalic vein at the wrist, or we have the brachiocephalic at the elbow, where brachial artery is joined with cephalic vein, or brachiobasilic, where brachial artery is joined with basic vein in the elbow. These are different types of AV fistulas. This is the most common. AV graft, again, the same places. If you instead of joining the artery and vein, you connect them with a tube. You connect with the straight graft, you connect with the loop graft, upper arm graft. The thing with AV fistula is, once we create an AV fistula, we have to wait for at least 6 weeks for that vein to increase in size. After you connect the artery and vein, the vein takes 6 weeks to increase in size and to become thicker. So for that 6 weeks, you cannot use that vein in an AV fistula. AV graft, after connection, within 1 week, you can start using the AV graft. That's the advantage of AV graft. But the thing is, since in artificial substance, it may not last long. It gets infected, it gets blocked. Fistula is the best option. Then we have the graft. Next, you have the catheters. This is the non-Turner temporary catheter, which you can use up to 1 month. This goes straight into interjugular vein and the heart. There are two ports, arterial and venous port, one port for drawing the blood, another port for injecting the blood. Both of them go into the internal jugular vein. Or this is the temporary catheter. This lasts for 2 months. To make it permanent, what we do is this external part, we bend it over, put it under the skin. Here it has just entered the vein here. So direct access for infection. Bacteria can enter the skin here, they be into the bloodstream. So more chance of infection. To prevent this entry, what we do is we create a tunnel. From this point where this point is where it has entered the vein. From that point, we make a tunnel inside the skin. And we get it outside. So in this case, the vein entrance is here. The skin exit is here. So this much part of the catheter is inside the skin. So whatever bacteria, they cannot go all the way here and enter the vein. So this decreases the infection risk. This is called a tenured catheter. You get tenured. This can stay for 6 months to 3 years depending on the usage. This is also not permanent. The best permanent solution is AV fistula. So for AV fistula, what to do is always save the non-dominant arm. Usually we prefer the non-dominant. Suppose a right-handed person, preserve the left hand. Unless suppose the left-handed veins are damaged, then you go for the dominant arm. If the non-dominant veins are good enough, always preserve it. Especially, so what do you do when the GFR starts going less than 30? In that, suppose left hand veins are good, I want to preserve the left hand. What I do? No BP measurements from the left hand from then on. No injections, no IV injections, no blood samples done. So nothing to be done of the veins, either injecting from the vein or taking sample from the vein, or no checking the BP anywhere so that the vein gets collapsed. You have to save the non-dominant arm. Whenever the GFR starts less than 30, you always save the arm. And you create an AV fistula. You plan for an AV fistula when you think that within 6 months or max 1 year, patient may need dialysis. It's not like patient needs dialysis now and you're creating a fistula now. This is the best scenario. You think that patient may need dialysis within 6 months, create an AV fistula and keep it. AV fistula is not going to harm the patient. Suppose in case of emergencies where you're not having any veins, you have preserved the left hand for fistula, but you need some emergency usage, then what you can use is you can use the dorsum of the hand, this part. These veins can be used for giving injections or putting IV cannulas. Because as we saw, AV fistula is created here. Radiocephalic or elbow. These are the veins which we use. So these veins here can be used for giving injections or taking blood samples in case of emergencies. As far as possible, try to avoid it. So in Western countries, what they do is they put a bracelet. There's a medical bracelet. So that whoever has a bracelet, whichever hospital the patient goes, they know that you should not touch this hand, even for BP measurements. So once you create the access, then the filter. So this is the dialyzer. What happens? You pass the blood from this port. As I told you, dialysis needs two solutions. Solution A, solution B, separated by semi-permeable membrane. So these fibers are the membranes. Within this, you can see these small holes. Once the blood enters here, it goes through each one of these pores and comes out to the other end. So solution A is a blood. Surrounding them is all these semi-permeable membranes. Solution B is dialysate. We pass through here. So that is present in the outside part. So blood is inside the small pores surrounded by dialysis, separated by the semi-permeable membranes. So this is where the dialysis happens. There are more than 10,000 such cylinders inside. So each of them acts as a semi-permeable membrane and each of them does dialysis. What we do is we push blood this way, top to bottom, and dialysate fluid bottom to top. We put it in opposite direction. So whenever there is opposite direction flow, there is better diffusion. The concentration gradient is maintained throughout the dialyzer, throughout the filter. So this is how the blood goes here, the dialysate goes here, separated by a membrane. So in blood, you can see toxins are highest here. Suppose creatinine is highest. The blood enters, the blood at the entry has highest concentration of creatinine. This creatinine goes into the dialysate and this washes off. So all the new dialysate which is coming has low concentration of creatinine. Whichever is filled up here is taken off. So that way the concentration gradient is maintained. Now here, once it starts coming down, the creatinine concentration of blood comes down because it has got already diffused. And here the dialysate is entered does not have any creatinine at all. So again, even if creatinine concentration, suppose this has a creatinine of 0. If this has a creatinine of 2 also, there is some diffusion happening. Here creatinine is 10. Here creatinine, it becomes 5, 10 to 5. Here creatinine comes down to 2. But in fresh dialysate, creatinine is 0. So even if creatinine concentration is very minimal, still diffusion happens. That's why we use the opposite direction. It's called counter current. So what are the membranes which we use? The dialysis membranes. The first one which we used was cellulose, just polysaccharide tryptophan, but thing was not biocompatible. A lot of reactions were happening. Then they modified it by adding acetate or diacetate to that. Again, not very good compatibility. It was better than before, but still some patients had allergic reactions to them. So then the synthetic ones came, which are the ones which are common use now. Polyaconitate, polysulfone, PMMC, polymethyl methacrylate, polycarbonate. All these things are synthetic ones where good biocompatibility, allergic reactions are almost minimal. This is how it goes. Fistula, always blood is taken away from the heart and blood is pushed towards the heart. So you take blood from the vein, the pump pulls the blood out, it is pumped through a dialyzer. To prevent clotting inside the circuit, heparin is given. Once in the dialyzer, again you have the counter current flow of dialysate, blood flowing this way, dialysate flowing this way, diffusion happens, the waste dialysate is again thrown off. The filtered blood sent back to the body. So this is what very complicated image. So RT, this is the blood pump. This is the dialyzer here. This is the acid and bicarb cans, and the waste dialysate goes at the back. So how do you know if dialysis is adequate? What we do is we check for urea removal. That is called KT by V. This KT by V, K is the removal of a substance, T is time, and V is volume of substance removed. Volume of the fluid which is cleared. So this is measured by the machine itself. So target should be more than 1.2 for every dialysis session. Every 4-hour session, you must target a KT by V of 1.2. One more what you can use, something called urea reduction rate. So at the start of dialysis, from the arterial line where the blood is coming, we take blood sample, measure the urea concentration in that. Again, the venous line where you're returning it to the patient, there you measure the urea concentration. The difference should be more than, at least more than 65% of it, of urea should be removed by dialysis. That means that good adequate dialysis is happening. So what are the complications we can see? We have dialysis reactions which can happen previously to the membranes. Now with the synthetic membranes not common, then we can have because of heparin or because of the disinfection we use. For dialysis membrane to disinfect, we use some chemicals. We can use formalin, or in the factories they use of gas. Gas is safe, or you can use ethylene dioxide. Ethylene dioxide is again it can cause dialysis reactions. Patient can develop hypotension, neuromuscular complications. Patient can have seizure, cramps, leg movements. Dialysis disequilibrium, especially when we're starting dialysis, you must not be too aggressive. If patient has KT of 10, you do not get it down to 2 immediately. To get it down too fast, your body, especially the brain, takes more time to adjust. So in that case, patient can become comatose, he can have seizures. So always the first dialysis should be slow. First dialysis slow, second bit more better, then third and fourth is where you actually pick it up. You don't straight away, you don't see a creatinine often and say, no, I have to get it down immediately. No, always go slow. Hemodialysis can happen. It can be because of water contamination, especially with copper. Then hypoxemia can happen. Post-dialysis syndrome is again cramps can happen, chest pain can happen. Arrhythmias and sudden deaths are very common because of pulling out blood and then shifting back. So whenever you're pulling out the blood, reflex activation of a sympathetic system gets activated, patient can develop tachycardia and arrhythmias. And Still syndrome, remember, fistula, we told you are connecting artery and the vein. So what happens if the artery vein, the entire arterial blood goes to the vein? If I connect it here, artery to the vein, if my entire arterial blood goes here, there is no blood circulation to my hand. This will become ischemic. That is called a Still syndrome. The AV fistula is stealing all the blood from the artery. Then again, dialysis associated hypoxemia. Then air embolism, if the catheter is open or if the arterial line which you put is disconnected, air enters inside. They can develop air embolism. So coming to PD. PD again same principle. It's again diffusion. Here what you're doing, your blood acts as the normal blood inside the body acts as a solution A. Dialysate you're putting into the abdominal cavity. You are creating ascites that acts as solution B. These both are separated by peritoneum. Peritoneum is a semi-permeable membrane. So one side you have blood, one side you have dialysate fluid. So once you push the fluid in, lock it, keep it for some time. We usually keep it for 4 hours. After 4 hours, in that 4 hours, the diffusion happens. After 4 hours, you open this part, the fluid comes out. So very simple procedure. So you have the peritoneal membrane with blood on one side and dialysate on one side. So all the toxins move out because toxins are in higher concentration in the blood. and the water also, because this in the diacet we use glucose. What happens? We use 1.5, 2.5, or 4.25% glucose to make it a concentrated sugar solution. So what happens when this concentrated, it pulls out water from the blood. So all the excess water in the body, that is called ultrafiltration. Removing water is called ultrafiltration. Excess water in the body is pulled out because of this concentrated glucose solution. Apart from that, you have creatinine, urea, and toxins have more concentration here. They with diffusion, they press the hemodialysis. Only thing is that it's artificial. Here we use the human membrane, inbred PD, peritoneal membrane. So different types of catheter, the straight catheter, bent catheter, coiled catheters, or with different stops in between to fix it in position. Any catheter can be used. There is no advantage of one catheter over the other. Whichever catheter is available with you, whichever catheter you are more comfortable with, you can use them. There is no advantages. One has to be used over the other. So what do? We put the catheter in the abdomen, just behind or above the bladder. This is the head end. This is the foot end. So this is where the patient's urinary bladder will be. So we put the catheter near the urinary bladder. So here, in fluid, whatever fluid you give, this catheter has multiple pores. All the entire catheter here has multiple holes in it. From here onwards, it's filled with multiple holes. So whatever fluid you give, it will leak out into the abdomen. And across, you can see all these capillaries, these blood vessels. So these all blood vessels. This is where this fluid comes in contact with. From that blood vessel, through this peritoneal membrane, it will diffuse out. So diffusion happens across this. So that's the inside part. The external part, you can get it out anywhere. Usually we get it out down, avoiding the waist end where the patient puts the belt. It's not be compressed. This is the internal part. Again, this is the inside the abdomen. This part is the tunnel, like how we do in a tunnel catheter. This part is under the skin to prevent infections. And from this cuff, some distance out, we mark the exit side. This is where the catheter will come out. So this part is hidden so that infection does not enter inside. This is what outside connections. This is how it looks like. Catheter is inserted into the abdomen here. From the abdomen, this part they have made a tunnel, and then it comes out. This is where you connect the fluid. So again, PD can be two types: continuous or intermittent. This is a CAPD, continuous ambulatory PD, where daytimes you do 3 times each. So dwell which I told you, you keep it for 4 hours. The duration depends on the patient's status, but initially we keep it to 4 hours and then adjust accordingly. So you can keep 4, 4, 4, 3 dwells in the day, and another 12 hours in the night. The entire 24 hours is covered. This is continuous. Or this is cyclic PD. Cyclic is where machine does. You just connect the machine to your catheter, which we saw before. It will keep exchanging at night. In the daytime, you put a single dwell for all the 10 hours. So this is continuous cyclic or continuous ambulatory. This is what is preferred in the West, where they do continuous dialysis, especially the continuous cyclic one, where the cyclic machine costs around 3.5 to 4 lakhs. So we don't commonly use in India because patients are not affordable. CAPD can be tried, but what generally we do is we do daytime CAPD. 3 bags or 4 bags in the day. That's it. Night we keep the abdomen empty and the patient take rest. Or if patient has cycle, only nighttime PD can be done. Nighttime done 8 to 10 or even 15 cycles depending on your adjustment, and daytime patient is empty. So there is no discomfort for the patient. These are different PD regimens we can follow. So this is how it is done. This insertion is somewhere here. Tunnel, exit side. Very, very neat. This is a cycle machine where you connect. You just ride on and connect the machine. The machine itself, it changes. You put all the bags connected to the machine. That's it. It will only take one after the other. Once they are complete, it will only throw the waste into this bag. So you just connect them and you sweep. When in the morning when you get up in the morning, discard the waste, switch off the machine. Or this is a CAPD in the morning. You have 2 liters bag, connect it. It takes half an hour to get filled in. Once it gets filled up, close this. This can be put. You have belt for this. You can hide it inside the belt, and you can do whatever work you want. 4 hours, you do whatever you want. You work in office, you go home, you work in a clinic, you work anywhere. Finish, you go do your work. You want to do housework, you can finish your housework. After 4 hours, similar kind of bag, put it down, connect it. The fluid will come out. So easiest thing. It does not hamper patients' daily activities. Hemodialysis, you have to come to the hospital, but for this, you can do it anywhere. Do once in the morning, once in the afternoon, once in the night, so you can keep doing your work. You do not stop your work. This is the advantage of CAPD. So which dialysis modality to choose between HD and PD? Contraindications: hemodialysis should not be done when patient does not have good BP or when the fistulas are not there, do not have vascular access. HD cannot be done. Or patient with severe heart failure, again hemodialysis cannot be done. It's bad for the heart. So coming for survival benefits, PD and HD, there is not much of difference. Both of them are equal. So again, there is no difference. You can choose any one of them. If you look for quality of life, we saw PD has better quality of life because they can do at their own comfort at home or whenever they want. Suppose I am a hemodialysis patient. I am staying in Vijayawada. I want to go to Bangalore. I cannot go because I have to come to my hospital once in every 2 days to get a dialysis done. But if I have PD, I can even go to America. I take my PD bags with me. I can stay wherever I want. I can do PD at home. So that's the advantage of PD. Quality of life is much better. But after 1 year, PD is better as long as patient's urine output is there. Once urine output goes down, suppose patient has zero output, that is all when the extension of the duration of dialysis, HD starts getting equivalent to PD. Initially, when the patient has to start dialysis, PD is also the best option. So if you look at treatment satisfaction, again, obviously PD is patients will be more satisfied because they have less morbidity, no need to come, no need of multiple injections. So again, satisfaction wise, PD is better. So basically, when we counsel the patients for initiation of dialysis, the main option we give is, as if the patient has good output, good urine output, PD is a better option, because once you do hemodialysis, patient's urine output starts going down. Because every 4 hours of taking out the blood and pushing it. So what happens at that time, the kidney becomes hypoxic. So if you keep doing hemodialysis, patient's urine output starts going down. It can become zero also. But that urine output is maintained for longer time in PD. Whereas again, if patient has heart disease, HD is bad for the heart because again, a lot of volume shifts and BP shift, PD is the best option. Or third, if patient does not have good veins. Fourth, especially in pediatrics, no kids, they need to go to school, they need to grow, they need to play, they need to eat well. We cannot keep getting them back to hospital and keep poking them. So in pediatrics, PD is the best option. On the vice versa, hemodialysis, when we choose, when the patient does not have output, no, very bad output, no output at all. In that case, hemodialysis is more effective than PD. The 4 hours which you do very effectively. So if patient does not have any output, hemodialysis is better. Or patient, on peritoneal dialysis, patient's KRT is going up, symptoms are not improving that well, then we go for hemodialysis. That is the option for hemodialysis. So then that is where residual renal function comes. Residual renal function is nothing but how much output patient is producing, even on dialysis. That is very important, because to maintain that, we generally prefer to put patients on PD. Why is that important? Because that will remove some amount of uremic toxins not removed by dialysis. It will maintain the fluid status, it will maintain the electrolyte status, it improves the quality of life. And it is shown to have a better survival. Patients with residual renal function have better output, better survival in both dialysis, both types of dialysis, when compared to patients who do not have output. So to preserve to preserve the residual renal function, what do you do? What happens if patient has good urine output, we do not restrict the fluid intake. So they can eat better quality of life, better survival. So what the common misconception, especially even physicians and everyone, is patient has gone into dialysis. So that means kidneys are knocked down. So you can give NSAIDs, you can give aminoglycosides, you give whatever you want. And your kidney is not working, they're doing dialysis. So you should not bother the kidney, you give aminoglycosides, giving NSAIDs is not going to do harm. That is wrong. Even if the patient's GFI is 1, forget 100, forget 90, even if patient's GFI is 1 to 2, you have to preserve the GFI. You don't say that patient is on dialysis, so I should not bother your kidney. That even 1 to 2 GFI, 0.5 GFI, each and every decimal there is important to improve the survival of the patient. So don't have that misconception. Many people have that patient is already on dialysis, kidneys are gone, so I can do anything I want. I give him diclofenac, TAD, I give him amikacin, I give him gentamicin. So even if kidneys are already not working, so I don't need to worry about kidney side effects. Always try to preserve patient's residual renal function even on dialysis. So what is the future of dialysis? We have regenerative medicine and stem cell therapy where they're trying to actually create the kidney again. And we have the web artificial kidney, where it's like a belt. So you don't need to have the fistulas and the PDs. It's just a belt which is put outside. The small tube connects inside. These are dialysate bags. You just put on the belt and go to your office. This is what this will come in another 5 years. It will be in the market. This is the next version of that. It's just a small box. They connect it to the artery and vein inside the body. It will do its work once in a week or once in 2 weeks. We have a small port here which has a bag connected to the outside. You just change the bag. You're not going to do anything else. There's a small port here. So it does all the work inside. Like a kidney sitting here, this sits inside the body. It's a small port, or you can even connect the waste into the urinary bladder. Or the waste, we go into the urinary bladder, patient will void urine. It's almost working your normal kidney. This is the next feature. This will come in 5 years. This, I think most probably in 10-15 years, it will be in the market. These are the futures of hemodialysis. So that was hemodialysis and PD dialysis. Now, what about the dialysis in ICU? We have hemodialysis, the same thing which you saw. Apart from that, CIRT, PD again instead of continuous, we have acute PD, which you do in ICU, and hybrid sustained low efficiency dialysis. That's in between these. So continuous start in 1980, it can involve either hemofiltration, hemodialysis, or both. You have arteriovenous, where you have one port in the artery and one port in the vein. The catheters normal which we saw, we put one in the vein. But arteriovenous, you can have one in the artery, one in the vein, especially in post-cardiac transplant or post-CABG patients. They have one in the femoral artery and one in the femoral vein. That is why you can have arteriovenous circuit. There's commonly venovenous is one which we prefer. You just put a single catheter which has 2 ports. You don't have two veins. Just one vein with 2 ports, 2 branches. That is good enough. So arteriovenous, again, hemofiltration, hemodialysis, hemodiaphy, depending on the access, arteriovenous or venovenous. These are CRT treatments. So in the venovenous, what happens is we use a blood pump, like how in a dialysis machine. A pump is there which pulls out the blood and pushes the blood. Arteriovenous pump is absent because of arterial BP, systemic BP. Artery is connected, arterial BP is 120, 140, 160. That pressure itself is enough to push the blood, no pump. So in hemofiltration, wherever you're using, as I told you, you need to push water. So to push the water, you need to give more fluid. So that is called as replacement fluid. Apart from the patient's blood, you add additional fluid so that you're pushing it to help in this filtration part, to do convection. CRT has a minimal hemodynamic disturbance, so it can be used even in patients BP 80 or patients BP having a BP of 90. So patients hypertension, patients post-operatively, and patients post-transplant, this is the best. So continuous arterifiltration is only arterifiltration means fluid removal, not dialysis. So this is in refractory heart failure or decompensated cirrhosis where you have a lot of fluid not responding to diuretics. What we do is it does not remove the solute. Kidney is normal, kidney function is normal, but heart is not working well. So much of fluid is accumulated and it's not coming out in the kidney because so much of fluid is there, kidney cannot excrete so much. So in that case, what we do is you do arterifiltration, only water removal. You put the catheter, push the blood at a speed with a blood pump and the pressure. Because of that pressure, water is washed off, water is pushed out. So we do not give replacement here because we want fluid to come out. So no replacement in this. Then acute PD, it is done bedside. You just need a simple catheter, or you can even do with in children, infants, we do with a normal IV line which you use. The IV cannula which you use, that is what we use for doing acute PD. So it can be done even at home. It can be done in primary head setup. So it does not need any specialized equipment. You can just use IV fluids and IV cannula. IV cannula can be inserted in the pediatric abdomen. Use IV fluid and normal saline or ringer acted to do the dialysis. Very easy to do, but thing is, since it's so easy, it's not so effective. And if patient has abdominal, suppose post-abdominal surgeries or peritonitis, we cannot use it. And you are filling up the abdomen with fluid, so it will push the diaphragm up and it compresses the lungs. So patient has a bad lung, again we cannot do it. And nursing, this fluid has to be changed. The fluid which you push has to be changed every hour. So every hour we need a person or nursing staff standing there, carrying the fluid, giving the fluid. So increased manpower is required, but it can be done any place. Sustained low efficiency dialysis, it's a hybrid between hemodialysis and continuous therapy. So it is something like you do hemodialysis, but with a lower pump speed, and for longer time. To decrease the speed of hemodialysis, decrease the effectiveness of hemodialysis, and to compensate, increase the duration of the time. So decrease the effectivity and increase the duration. In that way, BP fluctuations are minimized. So it can be done using a normal dialysis machine, no special equipment required. For CRT or continuous dialysis, you need special machines. So it can be done with normal nursing, normal manpower, and hemodynamically more stable. CRT is the most stable, then Z is stable, HD more chance of instability. PD is again stable in terms of BP. So to prevent, when you're using so many of outside circuits, putting the blood outside, blood can clot. So to prevent clotting, we use anticoagulation. We use either heparin, unfractionated commonest, which is used, or you can use omecavate heparin or heparinoids or thrombin antagonists like agatobin, etc. But most of the centers, 95% use heparin. Or something called regional citrate anticoagulation, where you put citrate in you take out the blood, in that circuit you put a citrate, and while you are returning the blood, in that circuit you put the calcium. Calcium antagonizes citrate. So here you give citrate, circuit does not clot. Before giving to the patient, give calcium, so patient will not have anticoagulation. Citrate effect is vanished. So it is only region, that is only within the machine there is anticoagulation. There's regional citrate anticoagulation, then it can be used in CRTs or when heparin cannot be given. One more option for regional anticoagulation, heparin and protamine, but very complicated, not used. So this was the conventional dialysis methods. So what are other ways where the similar principles are used or similar machines are used? Plasmapheresis. Plasmapheresis you do in multiple conditions where you want to, I told you, when you want to remove albumin, that albumin bound toxin. Suppose patient has some toxins which are albumin bound. In dialysis, we saw albumin is not removed. So non-protein bound toxins can be removed with dialysis. Protein bound, we use hemoadsorption. But if the albumin bound, we have to remove the albumin. Or patient has antibodies, COVID, for example, COVID or ARDS. No, suppose patient has very high antibody. COVID, if you want to take antibodies, you stop at this place. Remove the plasma, separate the plasma, you get COVID antibodies. Suppose we want to give suppose patient has ARDS, some other infections, leptospirosis or very severe sepsis, where you want to remove the bad the cytokines or inflammatory mediators in the blood and give patient antibodies. Suppose I have already recovered, I have antibodies. My antibodies have to be given. Or you need to remove some toxin from the blood. In that case, what we do is, we do plasmapheresis. This pass through a Dargan filter, plasma filter, which removes the plasma. The waste plasma is discarded. New plasma. As you take it from normal people or from other pooled patients, you take the plasma, infuse it. You can either, so this is the best method. We want to give antibodies. Or if you don't want antibodies, want just remove the waste, you can remove the waste plasma. Instead of giving plasma, we can give albumin. If you want to give antibodies, we give plasma. If we do not want antibodies, we give albumin. So that depends on the indication. Suppose post-transplant, you want to do plasmapheresis. Patient has rejection. So post-transplant, I do not want to give any additional antibodies to the patient. In that way, to worsen the transplant. So in that case, we won't give plasma. We give only replacement albumin. Or patient with myasthenia gravis, patient with lupus erythematosus, patient with GB syndrome. All these patients, you have to give beneficial components present in normal plasma. In that case, we give normal plasma. So depending on indication, we choose whether to give plasma or whether to give albumin. So how much you're taking out, that much has to be given in. Hemoperfusion. This is done in poisonings. See, this is something called this based on concept of adsorption. What happens? You take the patient's blood, pass it to an adsorption. Even this is done even for blood group incompatible transplants. Suppose patient has, suppose I have a blood group of A. My blood group is A, then I have antibodies against blood group B. So no one can donate a blood group B to me. If someone donates a blood with a group B in that, my antibodies react to that B group and it causes systemic reaction. So suppose I have a blood group of A and my wife has a blood group of B and I need a transplant. If suppose she has to give me the kidney, she cannot give because her kidney antigens are B, my kidney antigen are A. My antibodies will go and fight. So in that case, what we do is we use hemoadsorption. We pass specific hemoadsorption. So each adsorption curve is specific for each disease. So I want to remove antibodies against B. So I use a B antigen in this, pass my blood, all the B antibodies get stuck to the B antigen in this, and the remaining blood passed back to me. So what happens? The patient's antibody level comes down. Once the antibody levels come down sufficiently, then we can go ahead with the transplant. So that's how we do a ABO incompatible transplant, across the blood group transplant. Same thing can be used in many poisonings, pyracate poisoning. Many poisonings we use hemoabsorption. This is one more hemoabsorption. This much more better version. This is where you use not only for poisons, you can see all these things. These are like inflammatory markers, inflammatory mediators, interleukin 6, COVID-19, all of you heard of interleukin 6. So any patient with sepsis, patient with COVID-19, especially severe COVID-19, they use this filter. Something called cytokine absorption. Cytosorb. So all these cytokines are absorbed from the blood. These are the cytokines which are responsible for all the bad things, so hypertension, ARDS, the COVID storm, the cytokine storm which people talk in COVID. All these things are the ones which are responsible. So what you're doing by the cytosorb is you are absorbing them. You are decreasing the concentration of the blood. So you pass it through cytosorb, it absorbs it, then the normal blood, you pass it back to the patient. So that way you're decreasing the inflammation, decreasing the storm. And the next two are what we do in case of liver. This is not for kidney. This is not for patients with kidney failure. This is for patients with liver failure. Patient has liver disease, it's not working. He wants to do liver transplant, but there's not donor available. Donor may come in 3 months or 6 months. So that what we do this. This is the dialysis circuit which we use. This is called MAS, molecular adsorbent desiccation system. So the problem in liver disease is most of the toxin, that bilirubin and all of them, are albumin bound. Albumin bound toxins cannot be removed by dialysis, and you cannot keep doing plasmapheresis every day. So what they do is, patient's blood, they dialyze it. In this dialyzer, instead of using normal dialysate, what they use albumin. So here you can see patient's blood is filtered against albumin. So albumin is given. This albumin does not have toxins. Patient's albumin has toxins. So these toxins move on to this albumin, the albumin which you are giving. So this albumin, when bound with toxin, is again filtered. It is passed through an adsorbent. So these adsorbents absorb the toxins. So once the toxins from the albumin are absorbed, the albumin is again regenerated. Again pass it to charcoal again to remove all the possible toxins. The regenerated albumin again is circulated. So use external albumin, which is external patient 600 ml albumin is used, which is purified, again recirculated. This is the MAS system. The next better version is Prometheus. Prometheus, you don't need to give external albumin also. You just pass the patient's blood. This is something like a plasma filter where patient's albumin is filtered out. The patient's albumin itself is absorbed, passed through adsorbents and toxin filters. So patient's albumin passes through the adsorbents. Once it passes through the adsorbent, the toxins are absorbed. So the cleared albumin is gone back. The cleared albumin again dialyzes for removing other toxins, then conventional dialysis, and put it back to the patient. So you're not giving artificial dialysis, artificial albumin here. This is the difference between the MAS system and the Prometheus system. Both of them are expensive. They cost about 1 lakh per day. So that was a brief about the different dialysis. I could know a bit complicated things, much more in dialysis, but I don't know as of now whether you need much more detailed explanation than this. So any doubts or any clarification or interaction, we can go ahead now.
Thank you, sir. It was really an informative session. And we do have, sir, a few questions. Should we take up, sir?
Okay, ma'am. Sure, ma'am.
So the first question is, what is the treatment for peritonitis in patients with dialysis?
Okay. Peritonitis, if it develops because of PD, say CAPD, if a patient has peritonitis and there's a PD, peritonitis, what we do is we give antibiotics, we do a PD culture, peritoneal fluid is sent for culture, and you start them with empirical antibiotics for covering for both gram-positive and gram-negative. So that is cefazolin and cefazolin covers for the first generation cephalosporin, gram-positive, and third generation cephalosporin for gram-negative. Both 4 of them till the culture report comes. Based on the culture report, you continue the antibiotics. Most of them we give antibiotics for 3 weeks, except for Pseudomonas of growth, where if Pseudomonas peritonitis we give for 4 weeks. And tubercular and fungal peritonitis, we have to remove the catheter.
Okay, sir.
If other peritonitis, you can continue PD. No need to stop. Only in fungal peritonitis, we have to absolutely stop the PD.
Okay, sir. So there's another question. It
Yeah,
asks, what are the indications for home dialysis in COVID patients?
okay, the indications for dialysis are the same thing as I told you. AEIOU, irrespective of the cause. Refractory acidosis, ingestion of poisons, volume overload, electrolyte disturbances, or uremic symptoms. Any condition, because of, even if it can be AKI, it can be CKD, acute injury or chronic kidney disease, because of any cause. Those are indications for dialysis. Once you decide that the patient needs dialysis, then it is your call whether you want to do a hemodialysis or a peritoneal dialysis. In COVID, if a patient has very bad lung, usually it involves the lung, right? The patient has very bad lung, I will not go for PD because PD is very bad for lungs. It compresses the lung. So in that case, I go for hemodialysis. Once you think of hemodialysis, then it is up to you. You want to do it at hospital or you want to do it at home. It is up to you.
Okay, sir. So one more, then it says hypokalemia is a risk in dialysis. So how do we manage it?
Hypo or hyper?
Hypo.
Okay. Hypo. So the thing is, again for dialysate, the dialysate fluid which you use, the concentration depends. We have something what we call 0K, 2K, 4K. 0K means 0 potassium. 2K means 2 potassium. Conventionally, what we use is a 2K bath. The approximate thumb rule which you use is the difference between the patient's potassium and the serum potassium should be 4. It should not be more than 6, not be less than 4. So if patient potassium is 4, we use 2K bath. It will not come down to less than 4. Suppose patients already is having hypokalemia. Patient, we sometimes see patients with renal failure whose potassium is 2. We do not want the potassium to go even more down. So in that case, what we do is the dialysate, we add potassium. So dialysate potassium, we increase up to 4. So blood has a potassium of 2. Your dialysate has a potassium of 4. Then what happens? From the dialysate, potassium enters into the blood. High concentration to low concentration. That way you are increasing the patient's potassium. So you can add potassium to dialysate depending on your clinical indication.
Okay, sir. So there's a question from our forms which says management of neurological complications in dialysis.
Okay. Neurologic complications, DDS is the best treatment for DDS prevention. Clarity is high. Goes on dialysis. Once DDS develops, you can give hypertonic solutions to maintain the concentration of the blood. So what happens in DDS? Suppose hypothetically, I'm just giving an example, giving a number. 10 of 10 is present in the brain, CNS. Of 10 in the blood, you have concentration of 10. You start doing dialysis into 2 in the blood, but fast. It takes very, very slowly for the.
I think. So I'll join again.
Sorry, I think I got excited.
Yes, sir.
Okay, sorry. So I got cut. Okay. So
No,
what
it's
happens
fine,
is
sir.
you try to maintain the concentration. Suppose by inadvertently you maintain the concentration, you have decreased the concentration in the blood. Then what you do is you give dextrose, hypertonic dextrose, to increase the thickness or viscosity of the blood. So once blood viscosity increases, maintain it somewhere near the brain level to decrease the DDS. But ideally speaking, practically not much of treatment. Other neurological symptoms, like your patient has muscle cramps. Commonest cause of muscle cramp is removing too much fluid or removing too much salt. So give him salt, give him fluid. And to give massage. Massage of, suppose calf pain is there, calf massages, foot extension massages. Apart from that, we can give levocarnitin. Then apart, other things, ST6 syndromes or seizures, all these things are independent, depending on the exterior shift. So it's individual case dependent. Only muscle cramps commonly seen. For that, you give him saline, give him water, do exercises, levocarnitin.
Thank you, sir. So we do have few more questions.
Yeah, ma'am,
If
sure.
you have time, sir, we
So we
can
can
take
go ahead,
it.
ma'am. Yes,
Okay. Sir, how is fatigue assessed and managed in dialysis patient?
Okay, fatigue per se, quantitatively, we do not have a specific assessment. Fatigue, we just ask the history, but if you want, we assess for fatigue qualitatively or semi-quantitatively only if you are doing a study. You are doing a clinical trial or doing some new intervention. Suppose you are doing testing effect of exercise, that is why you study. In those cases, you have fatigue questionnaires. You have something called a Gordon questionnaire. You have a SF-36 questionnaire. You have multiple questionnaires which assess the fatigue score. So generally, what we just ask for the patient is he able to walk? Is he able to perform his routine activities? Is he feeling weakness? That just general history is enough. We do not go quantitative measurement. Fatigue is there. Again, there are multiple causes. One thing is inadequate dialysis, calcium imbalance, phosphorus imbalance, anemia, uremic toxins. There are multiple causes. You check which of them is the cause and treat accordingly.
Okay, sir. So there's another which says, is there a way dialysis can made economical for low income group people?
Okay, see, the dialysis cost as of now, it depends on which center you are doing and what type of setup you are. Suppose in our state, in Andhra, Vijayawada, we are doing dialysis. The lowest cost which you do is 1,080 rupees, 1,100 rupees per dialysis. And all of the 1,100 is reimbursed by the government. So most of the states have this government reimbursement where dialysis can be done free of cost. If you want to go to corporate setup, it charges around up to dialysis cost from 1,000 rupees to 2,500 rupees. So most of it is covered in the dialysis, and PD, if you take peritoneal dialysis, now we have the Pradhan Mantri Yojana, Ayushman scheme and the Pradhan Mantri Yojana that covers hemodialysis, that covers PD. So if a patient has a BPA card, if patient is enrolled into that, they can get it done free of cost. Transplant,
Okay,
I cannot say. Transplant cost is under concession you can do with insurances or the government schemes, but HDPD definitely has become free with the government insurance.
thank you, sir. So there's a question from Zoom. So it's, can you explain about more about intradialytic hypotension and what is the normal pressure?
Okay. Hypertension basically is no normal cutoff. What we call is a decrease in BP, more systolic BP more than 20 or diastolic BP more than 10. That we take as a cutoff approximately. There is no BP like BP of 120 or BP of 140. Suppose patient at the starting he has a BP of 160. It comes down to 100. That is hypertension for us. A patient per se has a BP of 100 by 60 from starting to ending. It is normal for him. So when you look at a degree of more than 20, we take it as hypertension. Commonest cause for hypertension is if you remove too much of water from dialysis. During dialysis, if you remove too much of water, so blood volume will come down, patient has hypertension. In that case, you maintain the blood volume. So some patients, some patients, diabetics especially, they can have autonomic neuropathy where BP keeps shifting. In that case, even if you do not take fluid, BP will fall down. So in this case, what we do is we increase the sodium concentration of the blood of the dialysate, increase the calcium concentration of the dialysate, and decrease the temperature. You make the blood colder, BP does not fall down. Increase the blood sodium, increase the blood calcium, BP remains stable. So these are the adjustments we do.
So another question from Zoom. What are the parameters should be taken care of for a fresh transplant patient? Either it may be heart or liver.
Okay, all the parameters individually depending on the organ to be done. If you're taken a heart transplant, you assume that the kidneys are normal, liver is normal, then you're only bothered about the pulmonary artery pressures. The thing which we check for in heart transplant is the ejection fraction and the pulmonary pressure. That's one way we monitor for ejection. So you're not going to the other the conventional hemoglobin, sodium, potassium. That's the conventional thing which you measure. If you take a liver transplant, you're going to monitor for the portal venous blood flow, the portal venous pressure, or whether the blood circulation is adequate in the portal vein. If the ejection is happening, first thing to get blocked, the portal pressures increase. And liver function test, the jaundice, liver enzymes, those are the things you are going to monitor. A kidney transplant, you're going to monitor for creatinine. Apart from that, in general, what we do is if a patient depends on, we monitor the immunosuppression. Most of them use calcineurin inhibitors, either cyclosporin or tacrolimus. One of them is definitely used to monitor for the blood levels of tacrolimus or blood levels of cyclosporin to maintain a dosage. And then keep following up for development of infections. That's it. No specific measures.
Sir, there's one which says, is there any special monitoring for pediatric dialysis?
No special monitoring. Pediatrics usually we prefer peritoneal dialysis because it gives them more freedom to play and work, to go to school, to eat. Quality of life is better. And second thing is you do not want to damage the veins. Pediatrics, suppose you have a patient with 6 years on dialysis, 6 years of age. You expect him to live for longer. You want to do transplant also. So keep hitting all the veins. So at the end of 15 years or 20 years, you're not left with any new vein for fifth year. So for quality of life and to preserve the veins, we do PD. No special indication per se. It is the same thing as adult hemodialysis. Only thing is the tubings, the dialysis filter, the blood tubings, all the catheters, all these sizes come down. So that because they have small lesser blood volume compared to adults, size of all the tubes come down. That's it.
Okay. So the last one, which is from registration forms, which says, what is dialysis-related beta 2M amyloidosis?
Okay, it's not beta 2 amyloidosis. It's either amyloidosis or beta 2 microglobulin. So this was what I spoke when we were talking about difference with diffusion and convection. Diffusion removes only up to 1000, whereas beta 2 microglobulin, the molecular weight is 12,000 to 13,000. The conventional hemodialysis which we keep doing, beta 2 microglobulin is not removed. So if you have a patient with 10 years or 15 years on dialysis, this beta 2 microglobulin keeps accumulating, and when that gets accumulated, it can accumulate in the joint, it can cause joint pains, it can cause neuropathies. That is called beta 2 microglobulin accumulation, or the same thing, it can form into amyloidosis. If you're doing the hemofiltration, beta 2 microglobulin is removed, so there's chance of this amyloidosis. Depends on what type of modality you're using. And okay.
Thank you, sir.
There's one more question which I got in Zoom. 3% priority about dialysis in pregnant patients, pregnant women. Pregnant women, especially in patients who are already on dialysis, pregnancy is not common, not likely to happen. But suppose you have a patient with acute kidney injury, pregnancy, or patient with stable CKD during pregnancy, they become dialysis dependent. What precautions we do is we put them on everyday dialysis. You do at least 5 days per week, or at the minimum most 3 days per week. We target a blood urea of 50. Normal dialysis patients have the urea of 100 or so, 80 or so, 90 or so, we don't bother. In pregnancy, increase the dialysis duration. You have to decrease the urea dose 50. You should not go above 50. And the bicarbonate concentration is reduced. Those are the things we adjust in pregnancy.
Thank you so much, sir. Here we declare our question and answer session and we end it. I hand over the session to my teammate, Yamini.
Thank you.
Thank you, sir. Thank you for putting the concept in such a simplified manner for us. It was really an insightful session. We also appreciate our participants.
Okay. I don't know how simplified it is. Definitely, I don't know. Okay. Yeah.
We also appreciate our participants' doubts being cleared. And we are now more excited to learn from you in the next session.
Okay, next session, I try to make it interactive. You people have to start interacting, because that will be more about pharmacodynamics and pharmacokinetics. So you people are more experts in that. Sir. So next question, next session will be more interactive, where you people have to start answering. Okay?
Yes, sir.
Okay. Sure, sir. Thank you so much, sir, for taking out time and delivering such a insightful lecture, sir.
Thank you.
Yes, Yamini, please continue.
I once again thank all our participants for joining in, and we hope to see you all on the second day of the session, which will be on 13th November, Friday. The topic will be drug dosing and dialysis.
Thank you.
Thank you, everyone.
Thank you, sir.